Well, the next speaker is Dr. Kunal from India, and he has his own standalone hematopathology and flow cytometry laboratories. And he is a special interest in hemato-oncology diagnostics with a focus on the CBC, bone marrow, flow cytometries, and molecular genetics. And he will give us the topics of the ESRs. So, Dr. Kunal, can you hear me?
Yeah, hi, thank you so much. I will just share my screen.
Yes, thank you, Dr. Kunal.
Yes. At the outset, I would like to thank the whole Mindray team for giving me this opportunity to share our experience about the ESR and the evaluation we did on the new BC-700 blood cell analyzer. So, good afternoon, everyone from India and other parts of Asia. And a few disclaimers to begin with. This original study was co-designed by Mindray and Sehgal Lab, with Dr. Coco from Mindray being one of the principal investigators along with me. The study was funded by Mindray, samples were provided by our lab and run with staff support from Mindray. The statistical analysis was done by the Mindray team and was co-analyzed by both our teams. So we'll start today's talk with the clinical significance of ESR, and I would like to thank Dr. Coco for sharing her slides regarding the ESR significance. As you know, the age-old traditional method for ESR analysis has been the Westergren method, which is the classic manual method. We measure over 60 minutes with these kind of tubes. And there has been a lot of advancement, and we have multiple automated methods, which we'll see along the way. So the traditional Westergren method was this long tube. You took a EDT or a citrate sample. The sample was diluted 4:1 using sodium citrate or normal saline. It is then loaded into this tube, which is typically a 30 centimeter long tube with a 2.5 millimeter bore, and it has multiple markings up to 200 millimeters. Now, we have to keep this tube straight and vertical with no slant, and then the fall of RBCs is read after 1 hour. This is typically done at 1825 degrees Celsius or the room temperature. Now, this is the classical Westergren method where it takes 1 hour to assess the aggregation of RBCs. Now, typically, if this is the whole blood, and at the end of 60 minutes, this patient has this much fall, whereas compared to second patient has a far higher fall. So, this patient has a higher ESR sedimentation rate as compared to the patient number one, which is sort of a normal sedimentation rate. So what is normal? Typically, for adults age less than 50, you will see for males it is less than 15, for females it is less than 20. As one grows older, the ESR might slightly increase. And if you read a few later papers, current day papers, people also consider as for males age by 2 as a normal reference range, and for females age plus 10 by 2 as a normal reference range. So for a 50-year-old lady, one might consider age plus 10, that is 60 years, divided by 2, that is approximately 30 as the ESR, which is very similar to what is shown over here. Practically, this is something which we can use in the day-to-day practice. Now, a lot of us over here might have used various, types of automated analyzers, which does, and few of the photographs of various companies giving these analyzers used. We might use the same CBC EDTA file. Many times they have separate EDTA, separate citrate files as shown over here. Now, importance is, any lab or a corporate hospital which has to use one more vial means it's an additional volume of blood which is being used for the patient. So typically, these various analyzers may have a reading within 20 seconds, 2 minutes, 20 minutes, or 30 minutes. So it cannot be actually measuring the same thing as the Westergren. What they do typically, the slower ones are the ones that do a mathematically derived ESR based on the aggregate measurements in the rouleau-forming stage itself. So these have to be, calibrated, manipulated, and there's some formulas and corrections which are put in various of these machines to actually compare it to the Westergren method. Now, typically what happens when we say we are measuring ESR? The RBCs which are individually start forming rouleaus, and the degree of velocity and the amount of aggregation is what happens at the end of sedimentation. They form clumps, which typically resemble stack of coins. This is what we measure as erythrocyte sedimentation rate. So what happens normally in the body is that RBC's membranes are typically negative charge. So they normally repel each other. Okay, so normally we have a low sedimentation rate even after a period of 1 hour. If there is anything in the body which reduces the negative charge, for example, albumin is a total protein which also adds to the negative charge, it will cause more repellation. But however, if there's inflammation, which means production of gamma globulins or decreased albumins, the negative charge on the RBC may be covered by the positive charge and there will be more of aggregation. So typically, acute phase reactants, fibrinogen, CRP, globulins, which will cause reduction in these repellents, reduction in the negative charge on the surface of RBCs, and hence more aggregates and hence more of ESR formation. So as I said, the membrane, the carbohydrate membrane is what causes the negative charge. Any factor which increases the repellence. For example, if in a case of severe anemia, the RBCs are so far away from each other, there's a decreased RBC density that the repellence is more. So that is, it may vary. And whereas it may lead to false ESR because, that. Whereas here, if you have example where you have increase in plasma fibrinogen levels, so or a gamma globulin, as I said, they will bind or they will cover up the negative charge on the surface of RBC. This will lead to increased sedimentation and an increased ESR. So typically, if one was to draw the erythrocyte sedimentation rate into a curve, you will see the green represents a normal and the red represents a high ESR curve. So the initial speed or the velocity in green is going to take time, which is slow. In red, it is going to be very fast before the peak or the degree of aggregation starts. And this angle or the degree at which the aggregation is happening, if it's a very acute angle, fast velocity, it is high ESR. Whereas this is a low angle and a slow velocity, it is going to be a normal ESR. Now, this is what the BC-700 analyzer measures. It measures the velocity of aggregation and it measures the degree of aggregation. Both of these are then calibrated into the machine to give us the actual ESR value, which is comparable to the Westergaard method. Now, various factors, as I said, can impact the ESR. Okay, so if you look at RBCs, WBCs, and platelet itself, as I said, anemia can increase sedimentation. So you get a falsely elevated ESR in anemia. Whereas polycythemia, there is more repellence of the RBCs and there is generally a decrease on a normal ESR. Now, if you have variation in size and shapes, abnormal RBCs, it is deagglutination or ruler formation. Ruler formation is typically because of increased gamma globulin. These are the factors which are going to cause an increase in ESR. Macrocytes lead to increased sedimentation. Whether it really clinically impacts or not is something which one would like to see. But size, shape, mass, external factors may all impact ESR. Now, let's look at plasma composition. As I said, albumin is one factor which, if it increases or if it is normal, will keep normal or decrease the ESR. However, if the albumin falls and the globulins increase or the fibrinogen increase, the repelling of the negative charge reduces and these all cause high ESR. So we know acute phase reactant happens in inflammation and infection. There's release of globulins, fibrinogen, which cause a high ESR. More viscous, lesser is the slower is the ESR. Less viscous fluid is faster ESR. Cholesterol, hypercholesterolemia may accelerate the ESR. So these were two factors on the RBC and the platelets. And then there are a lot of technical factors. What is the length of the tube? That's why the Westergaard tube has a standard length, standard wide bore of 2.5 mm, which I mentioned. Now, if you keep the tube straight, which is normal, which is the accurate way. However, if you tilt this tube, this tilting will impact the ESR. So 3-degree tilt can cause a 30% error. So in a mild tilt, this can lead to a false ESR. Typically, temperature will impact it and the tube diameter will impact it. Obviously, draft, sunlight, variations. So we should avoid all that. Static place, keep the tube straight to get a good ESR. As I said, in addition to pathological factors, and we mentioned these clinical factors like autoimmune disorders with increased gamma globulins, infections, malignancy, anemias, which can affect ESR, there are some physiological factors. One, as we age, there's a slightly ESR, higher ESR. Females, pregnancy status, obesity, all these may lead to factors with physiologically increased ESR. However, it is mild and not typically a 80, 90, 100 level of ESR. This is generally very mild. So let's look at part 2 of this talk, where we wanted to evaluate this analyzer, because one of the biggest advantages of this analyzer is that You run a CBC sample in the ESR mode, and along with the CBC result, simultaneously you get an ESR result. One, you simply use the same EDTA sample. Two is the extremely quick turnaround time. Three is a very valuable parameter with huge clinical significance, as you explained. It may not be very specific, but has huge value whether you're dealing with an infection or malignancy. So we want to compare this ESR results on the Mindray with the manual Westergren method. So what did we do? We took the leftover EDTA whole blood samples. We ran the calibrator, the daily control on the Mindray BC-700 machine, and we performed three parts of the study. A carryover study. So we did precision studies, repeatability and reproducibility, which I'll discuss, and then we did comparison studies. So for carryover, the principle is that if a patient has a very high ESR, will that high ESR leave a carryover onto the next sample and impact the result of my next sample? What if the ESR is 100 or 120 in one patient and the other patient is 2 or 5? Does it lead to a false high result in the next lower sample? For which there's a very standard formula where we run high target value samples with ESR more than 80, and we run low target value samples of 0 to 5. Using this particular formula given over here, we calculate the percentage carryover. Now, what we did this over 7 sets of samples, sample 1 to 7. And we see the carryover ranged from the lowest being 0%, the highest being 0.59%. Anything less than 1% is the clinical requirement for the carryover to be clinically insignificant. If you see, all the carryovers were significantly less than 1%. There was no problem, and the conclusion was the carryover study showed a fast result, indicating this is fit for clinical use. Now, we did 2 types of precision studies, and we're talking about repeatability and reproducibility. When I say repeatability, I am going to talk about repeating patient samples, and reproducibility was studied using quality control samples. So for repeatability, we had samples which are already run on the Westergren method, which had leftover volume of more than 2 ml. And we did 7 different levels. So ESR less than 10, 10 to 20, 20 to 30. So different brackets of ESR levels were taken. And these samples were run for 10 consecutive times in the ESR mode to evaluate the mean standard deviation and Sehgal. Okay. So if I take the level 1, the mean of level 1 was 5.5 and the mean of level 2 was 16.2. These both are within the normal range of less than 20. And the acceptance criteria as per the guidelines are given that if it's within the normal range, the acceptance criteria is less than 1.35 SD. Whereas if it is in the higher normal range or abnormal range, more than 15 millimeters, the criteria for acceptance of good performance is less than 9% CV. Now, if you see all our results of level 1 to 7, the CV was well below the acceptance criteria of 9%. And within the so-called normal range, this is slightly higher than the normal range of 15 to 16. But the SD criteria were also met at that level 1 and level 2, which is indicating that the repeatability across different levels of ESR was quite good. So next, let's talk about reproducibility. Now here, reproducibility sounds similar, but basically instead of using patient samples, we did quality control samples. And basically, after an interval of 5 to 12 hours, the quality control samples were run in the same mode 3 consecutive times for 5 days. There is no acceptance criteria stated, but only the performance evaluation in terms of precision is shown. Now, for CV of, if you see level 1, level 2, and level 3, all have a CV ranging from 0.9 to 1.4%, which we know is, even lower than 2% as such, very close to 1%, is clinically insignificant. And the mean values were for level 2 was in the normal range, level 3 was low normal, and this was slightly higher. While we don't have a 80-100 level of CV, but from both the repeatability and the reproducibility studies shown here, one can say the precision evaluation of ESR on this machine was quite good. Now let's come to the most important part is, if one was to use this in clinical practice, what is the comparison compared to the manual Westergren method? So there were 332 blood samples across different ranges and clinical conditions which were run. If one was to see simply the correlation coefficient, BC on this axis, Westergren result on this axis, the correlation coefficient was 0.944, which is excellent, which is as expected to have a close to one variable, which is quite a good result. However, just to showcase the data, we also did a bland Altman or the difference plot. In the bland Altman plot, we have divided the data into two parts. The first plot will talk to you about data within the normal range, that is between the 0 to 20 result. So let's focus on the data only in this particular region, 0 to 20 result, for which we are showing the difference in actually absolute form of the ESR value. So, values range from 0 to 6, 10, and then -2, -6, -10. So the mean difference is an absolute value of -2.6. So, there was slight under-reporting by the BC-700, but it's clinically insignificant with an SD which is pretty decent at 4.7. So at a normal range, pretty good results. Once we move from the data from 20 to 140, here instead of showing you absolute difference, we have shown you differences in the form of percentage. You see, there is slight under-reporting again, but the percentage is again very clinically insignificant, -3.56%. However, the SD was high, indicating yes, there were samples which are a couple of outliers. Yes, there is some outlier on the lower side and the higher side, and hence we are seeing a wide variation. But the actual mean difference was quite good and manageable. So to conclude my talk, as I showed, the performance assessment criteria for carryover, for precision, including repeatability and reproducibility, were very well met. There was a very good correlation coefficient of 0.944. The samples within the normal range showed practically minimal deviation and showed very good results. For samples within the abnormal range, above 20 specifically, though the mean bias was insignificant, a standard deviation of 28% was still noted. At the end, I would like to acknowledge the Mindray team, Dr. Coco being the investigator, Bhavna Parekh from Mindray, who did all the sample processing, Shama and Eric, who have coordinated various parts of the study and discussions, and Sri Yang for the statistic analysis, and all members from my team who helped me complete this study and present it to you today. With that, this is my team, and I thank you very much and be happy to take any questions.
Well, thank you so much, Dr. Kunal. Thank you so much for giving us the detailed information of the ESR evaluations. And I think you have introduced the details in the ESR detections, the influencing factors, the clinical significance, and the performance of our ESRs. We do notice there are some divisions, but I think those kind of division won't affect the clinical diagnostics, right?
Yes.
And everyone, if you have any questions, you can leave your questions in the chat box. Someone is asking that the Western grain is the gold standard, but there are many influences. What should I do if the ESR result of the instrument is inconsistency with that of the Western grain?
As currently Western grain is the gold standard, I would stick to the Western grain as of now. But it will be worthwhile evaluating. The repeatability of that sample on both methods. It is re-putting that sample and assessing why that happened. Is it only for that given sample, or is it happening more often in that clinical scenario? So, but yeah, in the end, if the answer is simple, I would then go by the Western grain, which is the time-tested method. And as I said, this is the true 1 hour measurement, whereas the others are sort of calculations, and one can have certain impacts which one is not aware of.
Thank you so much for your reply. And someone else is asking that have you ever tried to analyze the samples from cancer patients, especially for the multiple myeloma, and how the ESR values?
So, frankly, we did have a set of malignant samples from lymphomas, leukemias, as well as myelomas. I will be very frank, I've not been able to look at the data, but it's an interesting area. I will go back, specifically look at the myeloma high ESR and see a comparison of what we have got, and maybe, in the future study revert back to you on that. That will be an interesting area to look at. And I understand your question would be, whether the myeloma samples are giving an accurate result on this machine or not. I've not specifically looked at that condition. I don't think we have enough samples, but something worth evaluating for sure.
Thank you. And someone else is asking the acceptable CV for the ESR. Actually, for our ESR, that's in the different analysis range, like 0 to 20s and above 20s. So we have the different acceptable CVs. So we have already written it in our operation menus. And someone else is also asking for the commercial of the QCs. And actually, our ESR share the same QCs with the BC-60. The BC-60 is the QC of the hematologists. So it's use the same QC. It won't give you the actual cost. Someone is asking that is there any limitations for the multiple myeloma samples? And I think Dr. Kunal has already explained for it a few minutes ago, and he will go back to check the data in specifically to that kind of samples. Well, someone is also asking that could you please repeat the principles of the ESR? It's estimated by the Mindray instrument.
Eric, would you want anyone from your team or you to explain it, or should I just show the same slide again?
Sorry, Dr. Kunal.
Should I show the same slide again?
Okay. Thank you so much, Dr. Kunal. You can.
I'll just show the slide. And allow me to share my slide once more.
Okay.
So, while the exact algorithm is not what I am aware of, but typically, as I showed, if you compare, this is the green color is your normal ESR curve, whereas the red color is the curve at which a high ESR sample would move. In the first stage of ruler formation, the green color is having a normal speed, the velocity of aggregation, whereas if you see the red color curve is faster. So the velocity of aggregation is inversely proportional to the ESR. Faster velocity means high ESR and lower velocity means low ESR. And then the degree of aggregation, maybe the angle or the curve or the slant or the slope of the curve, whatever is measured by the instrument. Typically, if you see the red curve is moving at a more acute angle and going up fast. So this is the degree of aggregation. So what the analyzer measures is both the velocity and the degree. While velocity is inversely proportional, the degree of aggregation is directly proportional to setting velocity. Combining the two information is how the analyzer measures the ESR. I hope that answers your question.
Yes, I think you have answered the questions very clearly. And the last question is from Bijus. Well, there's so many questions, sorry. Bijou is asking that, have you observed the difference in the ESRs with the conventional glass tubes and the disposable plastic tubes? Yeah.
We haven't compared the conventional glass versus the disposable plastic. At that time in our lab, when the study was going on, we did have a very semi-automatic SEDI-10 analyzer, which we had, which also gave very good results. I also see another question, is there a comparison between 720 and Westmatic? No, I personally have no experience on this. The focus at this time of the study was between the Westergren and this auto analyzer and not between other methods. So I'm not sure if Eric and team can share some results on other analyzers if they have done it.
Yes, actually, we did the comparisons between the BC-720s and the Westmatic from Diagnostics in Spain. And I think the first speakers had already introduced the result. The correlations is also very good, about 0.9, like the 0.93, something like that. So we have these kind of studies, and I think we will have the publications from Spain as well. So thank you so much, Dr. Kunal. Thank you so much for your time, and thank you again for the excellent presentations to showing us everything in detail. Thank you so much.
Thank you.
So hi everyone. So in the last 1 or 2 minutes, I would like to share you something news. Give me one moment. So we have already talked about the key features of the BC-7 series and the KOL from the Spain, from Thailand, from India has already shown us the performance of our new parameters. And so in the end, I would like to take 1 or 2 minutes to give you something news. So far, so we are confidently to say we have the best solutions for the maternities and children's hospitals, or some hospitals and labs that has a lot of the neonatal samples. Well, firstly, compare with the other powders. So we have the small aspiration volume, only 25 microliters for the auto loadings. And secondly, so we can offer you more clinical values and more reliable results. In BC-7 series, we have the reportable nucleic acid red blood cells in every CBC test without additional cost. So as we know that neonatal samples always has a higher NRBC result, and we need NRBC to correct the WBC result in case of any misdiagnosis. But compared with the other competitors, the NRBC result was just the research use only parameters. And thirdly, is we have the microblood auto sampling and even the capillary blood auto sampling. We know that the neonatal samples were not easy to collect it. So insignificant blood collections will lead to an unreliable result. And if we use the tube like the Epidoc, so we need to manually mix it and manual sampling it. But now, our BC-7 series can support the BD microtensor auto loading. And if the sample volume was even lower, like 80 to 100 microliters, so we also have the optional configurations support to the microblood auto loading and even the capillary blood auto loading. So if you have any interest in these configurations, you can contact our local sales team for more information. So in the end, I would like to say thank you to everyone. Thank you for joining today's webinars. Please, please take 1 minute to scan the QR code below to complete the questionnaires. And thank you so much for supporting. If you need clarification for the webinars, so you can fill in the form with your full name and institution. Thank you so much.